So the question says 64-year-old man comes to the emergency department after developing fevers and chills during hemodialysis. He still feels feverish but has no sore throat, cough, abdominal pain, nausea or diarrhea. The temperature was 102, which is quite high at the dialysis center. The patient has a history of poorly controlled type 2 diabetes mellitus and hypertension, which led to end stage renal disease. He was initiated on long term hemodialysis 2 months ago. Patient has no known drug allergies. He does not use tobacco, alcohol, or insects drugs. The fever is 100.4. The blood pressure is 120 over 62, pulse 105, respiratory rate 22, oxygen saturation 96. There is a tunneled central venous catheter in the right jugular vein, and the skin around the insertion site is not erythematous or tender. The cardiopulmonary auscultation reveals clear lung field and normal heart sounds. Abdomen is soft and non-tender. No skin rash or skin stiffness is present. Leukocyte count is 14,000 with 90% neutrophils. That's quite high. Chest X-ray reveals no infiltrate or consolidation. Two sets of blood cultures, one from the peripheral vein and other from the central venous catheters, are obtained. Which of the following is the most appropriate immediate next step in management of this patient? So this patient, looking at the question, who has tunneled hemodialysis center and then developed fever with no localizing symptoms, should arise the suspicious for catheter related bloodstream infection, CRBSI. So the tunneled hemodialysis catheter are associated with much higher rates of bacteremia, up to 2 episodes per year, as compared to arteriovenous fistulas. Most cases are caused by coaguous negative Staph or the Staph aureus, but the infection with gram negative bacilli are also common. So we need to cover gram negative bacilli as well as Staph species. So this both has to be covered here. And if we look into the options, so vancomycin and cefepime quite do those things. So we have two options that could be possible here. The removal of catheter, send the tip for the culture and await culture result for antibiotic management should not be the option here, because waiting, the await should not be there because patient already has symptoms, the high grade fever, so he should be on the antibiotics, he should not wait. So removal of catheter, yes, this could be done. The one part of the question is right, that you should either remove the catheter or you should not remove the catheter. So the indication can be based on the following criterias. Either severe sepsis is present, which is not in this patient. Hemodynamic instability, patient is hemodynamically stable because blood pressure is okay. The evidence of metastatic infection, for example endocarditis, no, there is no evidence of endocarditis because normal heart sounds. Pus at the exit side of catheter is not given. The continuous symptom after 72 hours of empirical antibiotics. So first of all we are giving antibiotics and then we will wait. So removal of catheter should not be done here. So remove the catheter, no, this option is ruled out. Only vancomycin, it won't cover are both the bacteria, so D option should be also be ruled out. The vancomycin, cefepime and caspofungin, do we need all three things? The answer is no, we don't need all three of the coverage. So the addition of empirical caspofungin is typically recommended for patient with catheter related bloodstream infection related sepsis who have any of the following risk factors. The first is total parental nutrient, which is not in this patient. The second is prolonged use of broad spectrum antibiotics, which is not here. The hematological malignancy or the solid organ transplant, which is not there. Femoral catheterization or candida colonization and multiple site, which are not there. So E option is ruled out. So we have only one option left, and the answer here should be option B, that leave the catheter in place and you can just add vancomycin and cefepime. The vancomycin alone would not be adequate coverage against gram-negative bacilli, and catheter change over a guide wire should be considered once he is afebrile and clinically stable. Let's look at the other part of the question. Both the set of the blood culture grew MRSA, methicillin resistant Staph aureus. The patient's antibiotic regimen is narrowed to vancomycin only. So now we have only vancomycin, and tunnel catheter is removed. Now catheter is also removed. On day 4 of hospitalization, he continues to have intermittent fevers. So fevers are continued. Fevers has not gone. He has no cough, abdominal pain or diarrhea, but note a worsening back pain in his lumbar region, which he contributes to inactivity and uncomfortable hospital bed. The pain is dull ache and does not radiate. Examination reveals mid-line tenderness in the lower lumbar area. Neurological examination shows no abnormalities. Leukocyte remains elevated, so high leukocyte count 16,000. Repeat blood culture performed after venous catheter removed show no growth. So no growth of bacteria in the venous catheter. The plain radiographs of the lumbosacral spine reveals no abnormality. Echocardiography reveals no valvular vegetations. Which of the following is most appropriate next step in management? So here when you have Staphylococcus aureus bacteremia, it was given, it is MRSA, MRSA. So development of metastatic infection is around 40% in the patients. Metastatic infection. So the risk is increased or the greatest in those with community acquired infections or the treatment delay or persistent bacteremia or the persistent fever. The heart valve, lungs and osteoarticular structures are the most common side to be affected. So this patient has persistent fever, continued leukocytosis, worsening lower back pain, should rise for metastatic infection, and that to extent where to the site of spine, and where particularly spine, it is sacral lumbar region. The lumbar region is the site where the metastatic infection has been spread. So here we can say it could be vertebral it can be vertebral osteomyelitis, or it could be epidural abscess. It could be either of those. So the major manifestation is slowly worsening pain in the back or neck that localized to the affected disc space. Fever and leukocytosis may or may not be present, and blood cultures are positive in only 50% of the cases, because we saw that the blood culture, when the repeat blood culture performed after venous catheter removal showed no growth. So it could be negative in 50% of the cases. Here the question is, what is the best next step of management? So for vertebral osteomyelitis, often have normal plain radiograph during the first 2 weeks of infection. So this is the first 2 weeks of infection, and the plain radiograph shows no abnormalities, and which is quite normal, and therefore this study cannot be used to rule out early osteomyelitis. So the diagnosis of test is the choice of diagnostic of test is MRI of the lumbar spine. So is the option C. and for confirmation we require to do an open or CT guided biopsy just to confirm the diagnosis. Thank you.